Hi, my name is Dr. Wright, and I'm an outpatient mental health pharmacist at the Cincinnati VA, and I will be discussing depression and antidepressants. After this lecture, you should be able to have a better understanding of the DSM-5 depressive disorders, specifically the major depressive disorder, identify differences that exist in the current treatment guidelines for depression discussed in this lecture, define the key features and importance of the STAR*D trial and treatment of MDD, and then also formulate an individualized treatment and monitoring plan for patients with MDD. Here are some abbreviations you will see in the lecture. Throughout this presentation, we will follow a specific patient, MB, in her specific case. So I will start out with explaining that she's a 45-year-old female who presents to her primary care appointment. She has a past medical history significant for type 2 diabetes, hypertension, chronic pain, and hypothyroidism. She also has a family history significant for her mother having MDD and her father having type 2 diabetes. Her current medications include metformin, lisinopril, acetaminophen, and levothyroxine, and here are some pertinent labs to review. We will now review epidemiology or some background information on MDD. So depression is common. It's a chronic disorder that is both recurrent and disabling. It's estimated that 5% of adults suffer from depression, and it's a leading cause of disability worldwide and a major contributor to overall global burden of disease. The lifetime prevalence in the United States is reported to be 20.6%. In 2020, it was an estimated 66% of adults aged 18 or older with a major depressive disorder that received treatment in the past year. And then globally, it's an estimated 280 million people that suffer from depression. Risk factors for depression include being a female, being Native American, and having a first-degree relative with MDD. Other risk factors include being middle-aged, with the average onset being in the late 20s. Also, if you have a stressful life event such as unemployment, loss, traumatic events, major life changes, or domestic abuse or violence. Also, if they are recently widowed, separated, or divorced, if they have low income, any chronic medical illnesses such as diabetes, cardiovascular disease, chronic pain, cancer, or even HIV. Another risk factor is if they have comorbid psychiatric or personality disorders. This can include a personal history of MDD or even substance use. Another risk factor would be if they have previous episodes of depression, and this actually increases with the number of episodes. So if they had one prior episode of MDD, it's 50% chance they will experience a future episode. If they had 2 prior episodes, there's a 70% chance they may experience a future episode. And then if a patient has had 3 or more episodes, it's at least 90% chance that they will experience a future episode. We will now return to MB, who comes in with the chief complaint of, "I don't know what to do anymore." She further explains that last month she separated from her husband and has had to share custody of her children. She has never had this feeling before but feels like the world is ending. She denies any suicidal thoughts because she could never leave her children. So what risk factors do you think MB has for MDD? I'll give you a minute to think about it. So as you can see, she is female, so that puts her at higher risk for MDD. She is middle-aged at 45, has a history of diabetes and chronic pain, and recent stressful events with separation from her husband. And then she has a first-degree relative, her mother, with a history of MDD. Now going into the pathophysiology of major depressive disorder, the exact cause is still limited, but neuroanatomical abnormalities show differences among patients with MDD, specifically the frontal cortex, the limbic structures, and the hypothalamus. The prefrontal cortex is involved in decision-making, and the limbic structures play a role in stress. So decreased activity in areas of the frontal lobe, specifically the dorsolateral prefrontal cortex, and increased activity in the limbic structures, including the amygdala and subgenual anterior cingulated cortex. This corresponds to clinical studies showing MDD patients dysregulation of emotions, particularly responses to stress. Additionally, higher blood concentrations of stress hormones are found in patients with MDD. The prefrontal and limbic structures communicate with the hypothalamus, which controls release of these hormones, and dysregulated communication of these structures are thought to be responsible for abnormal concentrations of stress hormones in patients with MDD. On a molecular level, disruption or dysregulation of serotonin, norepinephrine, and dopamine transmission, also seen in patients with MDD, may impair the feedback loops that turn off the stress response. Stress results in release of glucocorticoids and corticotrophin-releasing hormones, and pro-inflammatory cytokines. Inflammatory cytokines further interfere with the functioning of serotonin, dopamine, and norepinephrine, and neurotrophic signaling, particularly with the brain-derived neurotrophic factor, or BDNF, in the hippocampus. They may also diminish central corticosteroid receptor sensitivity, leading to disruption of feedback control. Historically, the monoamine hypothesis developed in the 1950s after it was discovered depletion of neurotransmitters including serotonin, norepinephrine, and dopamine led to depressive symptoms. And that depressive symptoms improved with increased monoamine activity with MAOIs and TCAs. But this hypothesis does not account for delayed onset of effect on mood, which is seen with antidepressant therapy, in relation to increased synaptic neurotransmitter concentrations. The dysregulation hypothesis better accounts for the explanation in the delay in onset of antidepressant action. It is hypothesized that depression results from dysregulation of neurotransmitters that leads to alterations in both pre- and postsynaptic receptors, rather than simple increases or decreases in their concentration. The normalization of receptors in response to antidepressant therapy is delayed in relation to changes in synaptic neurotransmitter concentrations. The chronic stress model may further explain depression and stress effects on the hypothalamic pituitary adrenal axis, which is explained by the picture. So stress effects on the HPA will lead to secretion of glucocorticoids and cortisol. These stress hormones deplete BDNF, which then leads to a decrease in neurogenesis in the hippocampus. Studies have shown patients with MDD have atrophy of the hippocampus, and antidepressants are effective treatment because they will increase neuronal cell proliferation in the hippocampus. Because our understanding of depression is limited, this also limits the ability to really treat the disorder effectively. Now to review the DSM-5 diagnostic criteria for MDD. It is characterized by one or more major depressive episodes with no history of manic or mixed mood episodes. The criteria for major depressive episode includes 5 or more of the following symptoms that must be present nearly every day for at least a 2-week period, and the symptoms have to result in a change in level of functioning. And they have to have at least one of the symptoms is either being depressed mood or loss of interest or pleasure. So the following, it includes depressed mood most of the time and on most days. It can be expressed by subjective reports such as feeling sad or reported by others where they say they may appear tearful. And irritable mood is usually noted in children and adolescents. They can have decreased interest or pleasure in daily activities most of the time and on most days. This is by subjective reporting or noted by others. Have significant changes in weight, either a change of more than 5% of body weight in a month, or appetite. Weight loss when not dieting, or weight gain, or a decrease or increase in appetite are usually observed. In children, we consider a failure to meet age-appropriate weight gains. They can have significant changes in sleep, whether it be insomnia or hypersomnia, psychomotor agitation or retardation, which is observable by others and not just subjective feelings of restlessness or being slowed down. They may be fatigued or have decreased energy, have feelings of worthlessness or inappropriate guilt, which may even be delusional, decreased concentration or difficulty making decisions, and this is either by subjective account or observed by others, recurrent thoughts of death, so not just fear of dying, suicidal ideation without a specific plan for committing suicide, or a suicide attempt. And then these symptoms must result in significant distress or impairment in daily functioning, and the symptoms cannot be secondary to substance use or a general medical condition. So returning back to MB, when prompted more about her recent mood, she describes the following. She has felt this way for the past month nearly every day. She's unable to go to her job as a nurse and she's constantly calling in, which has resulted in being behind on her bills. She used to love spending time with her children, but now she's usually found on the couch or in her bed while they play with the neighbors. She's sleeping more than 12 hours a day, which is unusual for her. She has no energy to get up for the day. And since experiencing this low mood, she's just felt that her children don't deserve her as a mother. She feels she should be doing more, but she really just can't. And then when her parents come to visit, they notice she was generally just kind of moving slower with no purpose to her actions. They tried to spend time with her and suggested playing a board game, but during the game she just really seemed distracted and couldn't concentrate on the game. MDD can be classified by the severity of the episode. The severity is usually determined by the number and severity of diagnostic criteria met in degree of functional impairment. Mild consists of 5 or 6 depressive symptoms and minimal functional impairment, whereas severe consists of nearly all symptoms present with significant impairment in functioning. MDD can also be present with psychotic features, where the episode is characterized by delusions or hallucinations, and these are usually auditory. With psychotic features, these can be either mood congruent, where they have delusions of guilt, derogatory auditory hallucinations, or they can be incongruent, where they have no relationship to the depressed mood. If they do have mood incongruent features, that usually indicates a worse prognosis. Remission is usually considered after having absence of significant symptoms for at least 2 months. And then partial remission is defined as either continued presence of some symptoms, but full criteria is not met, or the symptoms are no longer present, but the duration is less than 2 months. And then chronic MDD is defined as meeting the full criteria for a major depressive episode for a minimum of 2 years. Based on what MB described, what severity of MDD do you think she has? So I would classify her probably as moderate to severe based on the amount of symptoms she reported, and she's having functional impairment where she's not able to go to her job, not able to get up and do activities that she used to enjoy doing. In addition to psychotic features, there are other descriptive specifiers for MDD. First one is anxious distress. So this is where episodes are present with 2 or more of the following, including tension, restlessness, impaired concentration due to worry, fear regarding future events, or fear of loss of control. It's usually associated with a higher suicide risk, a longer duration of illness, and a greater likelihood of treatment non-response. You can also have mixed features, and these episodes are present with 3 or more symptoms of mania for most days, but it does not meet the criteria for a manic, hypomanic, or a mixed episode. It's usually found to be a significant risk factor for the development of bipolar disorder. It's also catatonic features, so this episode is present with profound, purposeless psychomotor changes, so immobility or increased motor activity, or mutism. It does require 2 or more of the following: motoric immobility, so catalepsy or stupor, excessive purposeless motor activity, extreme negativism, peculiar voluntary movements, or echopraxia. Melancholic features is a severe form of depression and is characterized by loss of pleasure in activities or lack of reactivity to pleasurable stimuli. It does require 3 or more of the following: distinct quality of depressed mood, so significant despair or an empty mood, increased morning severity which improves as the day progresses, early morning awakening, marked psychomotor agitation or retardation, significant anorexia or weight loss, or excessive or inappropriate guilt. Atypical features is usually characterized by mood reactivity, so their mood will brighten in response to actual or potential positive events, and it requires 2 or more of the following for most days: significant weight gain or increased appetite, increased sleep, long-standing pattern of sensitivity to interpersonal rejection. There's also peripartum onset, so this is the onset of symptoms that occurs during pregnancy or within 4 weeks after childbirth, and it may or may not be present with psychotic features. The last one is seasonal pattern, so it's recurrent MDD with mood episodes occurring repeatedly at specific times of the year. So usually it falls in the fall and will remit in the spring, but can occur really at any time during the year. It does require a consistent temporal relationship between the onset of the episode and that particular time of the year. And remissions usually occur at a characteristic time of the year. They do have to have at least 2 major depressive episodes that have occurred in the past 2 years that demonstrate this seasonal pattern, and have no non-seasonal major depressive episodes that have occurred during that same 2-time year period. These seasonal depressive episodes should outnumber other depressive episodes throughout this patient's lifetime. And again, the pattern can't be better explained by seasonally related psychosocial stressors going on. Now we're going to go into the type of treatment or the medication classes of antidepressants. So these treatment classes are broken down between first and second generation agents. The second generation agents are more selective. The increased selectivity is specifically responsible for better tolerability, as TCAs have increased anticholinergic side effects due to their affinity for alpha, histamine, and muscarinic receptors. In general, onset of antidepressants are not quick, and it may result in decreased adherence overall. It can take anywhere from 4 weeks to sometimes maybe even 6 to 8 weeks, although no agents are more efficacious than another. So first-generation agents consist of your tricyclic antidepressants and your monoamine oxidase inhibitors, whereas our second-generation agents consist of selective serotonin reuptake inhibitors, or SSRIs, selective norepinephrine reuptake inhibitors, or SNRIs, bupropion, mirtazapine, and trazodone. We also have newer antidepressants including vilazodone and vortioxetine. We'll start by reviewing the SSRIs. Their mechanism, as you can see in the picture, this is a simplified version of their action. So they inhibit presynaptic serotonin reuptake. This occurs by interfering with the serotonin transporters, which eventually leads to an increase in serotonin in the synaptic cleft. Their side effects include headache, which you can recommend taking at bedtime to help with that, weight gain, GI upset, which you can recommend taking with food or take at bedtime, sexual dysfunction, and recommendations for that usually include decreasing the dose. You can switch to or add a non-serotonergic agent, such as bupropion, which we will discuss later, or switch to or add a medication with 5-HT2A receptor antagonism, such as mirtazapine or nefazodone, which we'll also talk about later. Switch to vortioxetine, which we can also talk about later. Or you can add on an agent with partial 5-HT1A receptor agonism, such as buspirone, or you can consider a PDE5 inhibitor, such as sildenafil, also known as Viagra. They can also cause agitation or anxiety, and we recommend usually just starting low and titrating slowly with that. And here is a list of the SSRIs. We have citalopram, escitalopram, sertraline, paroxetine, fluoxetine, and fluvoxamine. As you can see, the initial doses are here, but each patient will have specific recommendations for them based on their past medical history and other medications as well. So just some general notes about some of the medications. For citalopram, the QT prolongation is dose dependent, and it is a side effect of this citalopram. So labeling does change to reflect the max dosing of 40 milligrams per day, and that's in healthy adults. You should limit the dose to 20 milligrams in patients who have hepatic impairment, if they're more than 60 years old, if they're CYP2C19 poor metabolizers, also if they're taking cimetidine, omeprazole, or other CYP2C19 inhibitors. For fluoxetine, it is characterized by a long half-life, so this can be up to 4 weeks long, and it's also associated with QT prolongation. Paroxetine is actually opposite in that it has a short half-life, so this puts it at higher risk of what is known as discontinuation syndrome. Some symptoms with discontinuation syndrome include anxiety, irritability, insomnia, headache, and nausea, and we try to prevent that by slowly tapering off of the antidepressant. And sertraline also has a risk of QT interval prolongation. Now moving on to SNRIs, they essentially work on serotonin receptors similar to SSRIs, but they also inhibit presynaptic norepinephrine by inhibition of the norepinephrine transporters. This overall leads to an increase in serotonin and norepinephrine in the synaptic cleft. Some class side effects are similar to the SSRIs given their ability to block serotonin reuptake. But in addition, they also have norepinephrine effects, so this can cause hypertension and sweating. It can also cause dry mouth, where we can consider saliva substitutes, recommending maybe sugar-free candy, or increasing their fluid intake if appropriate for that patient. The SNRIs consist of duloxetine, venlafaxine, desvenlafaxine, and levominacepran. As you can see here are again the initial doses for those medications. Duloxetine and venlafaxine can also be used for pain disorders as well, where duloxetine has benefits in musculoskeletal pain and nerve pain, and venlafaxine has benefits in nerve pain only. Duloxetine does inhibit norepinephrine transporters to a greater degree than venlafaxine, which does result in a higher incidence of dry mouth and constipation. Venlafaxine and desvenlafaxine may increase cholesterol and triglycerides. Venlafaxine does preferentially bind to the serotonin transporter at doses under 150 milligrams daily, and then inhibits the dopamine transporter at doses greater than 450 milligrams daily. With levominacepran, it was the most recent SNRI that was approved. It does have a higher affinity for norepinephrine transporters versus serotonin transporters. Now we'll move on to the tricyclic antidepressants. There are two types, tertiary and secondary amines. They work by increasing serotonin and norepinephrine in the synaptic clefts. This is through inhibition of the presynaptic serotonin and norepinephrine reuptake by inhibiting the serotonin and norepinephrine transporters. They also bind to alpha, muscarinic, and histamine receptors, which makes their class less tolerable because it increases anticholinergic and cardiovascular side effects. We do use caution in suicidal patients because they have the potential for overdose from these cardiac effects. Generally, the secondary amines are better tolerated. In general, we do see more sedation and anticholinergic side effects with tertiary amines, and then we see more cardiovascular side effects with the secondary amines. Here they are separated. So tertiary amines, which have a greater affinity for the serotonin transporter, include amitriptyline, imipramine, clomipramine, and doxepin. Secondary amines, which have greater affinity for the norepinephrine transporter, include nortriptyline, desipramine, and amoxapine. So with their norepinephrine properties, they are also used in pain disorders, mainly amitriptyline. The initial doses of amitriptyline, imipramine, and desipramine, as you can see here, can also be given in divided doses as well. Usually all these tricyclic antidepressants are given at bedtime because of their risk for sedation with the anticholinergic side effects. Another note is that doxepin is actually approved for insomnia, but it is at doses lower, starting at 3 to 6 milligrams daily, whereas the antidepressant doses are higher, where you see we start with 25 to 50 milligrams daily. Next is the least favorable monoamine oxidase inhibitors, or MAOIs. These have generally fallen out of favor due to their drug interactions, dietary restrictions, and side effects. They work by irreversibly inhibiting monoamine oxidase, which prevents metabolism of norepinephrine, serotonin, and dopamine. Some drug interactions include amphetamines, carbamazepine, decongestants, ephedrine, and dextromethorphan, and then also tyramine-containing foods, as all of these can cause hypertensive crisis. Some tyramine-containing foods include aged meat, cheese, soy, anything aged, or like beer as well. Some of the MAOIs include tranylcypromine, phenelzine, isocarboxazine, and the selagelene transdermal patch. So after stopping treatment with an interacting medication, you usually have to have a time period about 4 to 5 half-lives of the medication or the active metabolite to elapse before starting MAOI therapy because of the drug interactions. And then if you're stopping the MAOI, you have to have at least 2 weeks elapse before starting therapy with a medication that is contraindicated. Now we're going to move on to individual medications that have their unique mechanism of actions. We'll first start with bupropion. It works by inhibiting dopamine and norepinephrine transporters. It increases dopamine and the norepinephrine concentrations in the synapse. You can see the initial doses here. It does come in different formulations. We have immediate release, a 12-hour extended release, and then a 24-hour extended release. Zyban, that is 12-hour dosing, is also approved for tobacco use disorder. There is a higher incidence of insomnia, anxiety, and seizures at higher doses, and some risk of hypertension with bupropion. It is unique as it has no serotonergic effects, which may be why we see less sexual side effects with bupropion. Some contraindications include seizure disorders and current or prior diagnosis of bulimia or anorexia, as it can cause electrolyte abnormalities and therefore increased risk of seizures. Next, we have mirtazapine, which increases synaptic concentration of serotonin and norepinephrine through presynaptic alpha-2 antagonism. It also has a 5-HT2 and 5-HT3 antagonist and histamine 1 antagonist mechanism. The 5-HT3 receptor activity is thought to be responsible for better tolerability, as the receptor plays a role in decreasing nausea. It also can cause QTc prolongation, similar to other antidepressants. It is very sedating, therefore it is ideal for patients who have insomnia with MDD, but it's usually not for those with an increased BMI, as it could lead to an increase in appetite and therefore weight gain. It can also cause hypertriglyceridemia, and rarely, but we watch for, is liver toxicity and agranulocytosis. Now moving on to trazodone, which you have likely heard of, and then nefazodone. They work through weak inhibition of presynaptic serotonin and norepinephrine reuptake, more so for nefazodone. They also have 5-HT2A antagonism, weak alpha-1 antagonism, and a histamine 1 antagonist, which is more so for trazodone than nefazodone. They both do have significant somnolence, which does make it difficult to reach therapeutic doses to treat depression, and therefore are used mainly for sleep at their lower doses. Trazodone is the most common seen today, as nefazodone does require routine LFT monitoring because it can cause hepatic failure. In addition to the somnolence, trazodone can cause nausea, dry mouth, and dizziness, as well as nefazodone. Now we'll review some of the newer antidepressants, starting with vortioxetine. It was approved in September of 2013 for treatment of MDD. It works similar to SSRIs, but it also involves 5-HT3, 1D, and 7 antagonist, and 5-HT1A agonist. It also has 5-HT7 antagonism, which is thought to enhance the activity of SSRIs. It possibly leads to faster onset of symptom improvement as well. So for side effects, it has nausea, kind of similar to other antidepressants, that was usually persistent during the 8-week trials. It has diarrhea and dry mouth. It also has sexual dysfunction as well as similar to other antidepressants. Then we have vilazodone, which is the last medication we'll talk about in detail. It was approved in January of 2011 for the treatment of MDD. Its mechanism is through serotonin inhibition, and it's also a 5-HT1A partial agonist. This leads to increased serotonin in the synaptic cleft. It also may have some affinity for norepinephrine and dopamine transporters. Similar to other antidepressants, some of its common side effects include diarrhea, nausea, and insomnia. So just kind of to generally review some of the adverse side effects with these medications, you can see here it's listed as what can cause positive of these adverse effects and what can cause negative. So increased sedation is caused by paroxetine, mirtazapine, and trazodone, whereas bupropion, fluoxetine, and sertraline may cause insomnia. For weight gain, paroxetine and mirtazapine can increase weight, whereas bupropion, duloxetine, and fluoxetine may cause normal weight or decrease weight. Bleeding risk is increased with SSRIs, but it does not have usually an effect with bupropion or mirtazapine. With sexual dysfunction, we generally see it with paroxetine, venlafaxine, or sertraline. It's less with mirtazapine and vortioxetine, and we don't see it with bupropion, as we discussed before, because there's no serotonergic effects. Then bupropion and venlafaxine can increase your blood pressure and cause hypertension, whereas SSRIs do not generally have that effect. Just to review some other significant side effects, these are just general side effects of antidepressants. They include hyponatremia, which occurs more commonly with SSRIs, so we want to use caution in the elderly population. There's also serotonin syndrome with serotonergic agents. It is rare, but we want to use caution with other serotonin modulators that aren't just antidepressants. It is where excess serotonin is in the CNS, which causes increased temperature, confusion, agitation, and increased blood pressure. Can also, in severe cases, cause seizure and death. There's also discontinuation syndrome, which is where we have like flu-like symptoms that occur after abruptly stopping an SSRI or SNRI. So as we kind of mentioned before, we want to taper slowly. One exception is fluoxetine because of its long half-life, doesn't usually have discontinuation syndrome. There's also the side effect of suicidal ideation, which is not really known how prevalent in a population it is already at risk for suicide, but it does require close monitoring, especially with a previous attempt of suicidal ideation. Then, as we discussed before, there is sexual dysfunction with antidepressants, which is usually likely related to the serotonergic effects, so you may try bupropion as an alternative or add it on as an additional medication. And then again, some medication can cause decreased seizure threshold, so we want to be cautious with bupropion. So now we're going to talk about the STAR*D trial, which was the landmark trial in depression published in 2006. So it was designed with the overall goal to assess the effectiveness of depression treatments in patients that were diagnosed with non-psychotic MDD, and this is in primary and specialty care. It was the largest and longest study that included comparison of different treatment strategies in the outpatient setting, and its results did influence guideline recommendations for antidepressant treatment. So STAR*D did compare acute and longer-term treatment outcomes and is associated with each of 4 successive steps. So it did start out with 3,671 patients in step 1 and then got to 123 patients by step 4. Patients were started at level 1 with treatment with citalopram, as you can see here. Those that did not achieve remission or were unable to tolerate treatment were encouraged to move to the next step. Then those who achieved remission could enter a 12-month naturalistic follow-up phase from any treatment step. The cumulative remission rate was only 67%, but overall individuals required more treatment steps. The individuals that required more treatment steps had higher relapse rates during the naturalistic follow-up phase. So really, in conclusion, when more of the treatment steps were required, as you can see them here in the figure, they had lower acute remission rates, especially once they got to the 3rd and 4th step. And then higher relapse rates did occur as you did the follow-up phases. So when we think about the goal of antidepressant treatment, we really want to treat to achieve remission. Other goals include improving their overall quality of life and functioning, which are kind of difficult if there's residual symptoms or a partial response that's persistent. Unfortunately, many studies have shown up to 2/3 of patients will not experience full remission with the first antidepressant treatment. And that's why it's important to define remission status as partial or full remission, and then better characterize the patient's response to certain treatment strategies. So if we look at this picture, antidepressant treatment is initiated, and then there's the acute phase of the episode that continues anywhere on average from 6 to 12 weeks. Then we consider partial remission as persistent residual symptoms of the previous episode that's present, but it doesn't meet full criteria. And then you have also full remission. So that means there's no significant symptoms of the disturbance in the past 2 months. While up to 35% of individuals continue to experience residual symptoms, 15% will never achieve remission, and this is where we consider it chronic depression. So then over the next 4 to 9 months, this is what's known as the continuation phase, where treatment is continued and after a year reach the maintenance phase, where a patient will be considered either to be in recovery from the major depressive episode. A relapse is likely if less than 2 months have passed since the last episode, meaning that remission from the previous episode was never achieved. We define recurrence as an additional episode that occurs once recovery was achieved. And then as we discussed kind of earlier, if patient has had one prior episode, they have a 50% risk of developing another episode, and then that risk continues to increase with more episodes in the past. The time it does take for patients to achieve response and remission is important and can influence the future prognosis and their future relapses. So drug therapy is kind of difficult to measure, and the guidelines recommend the use of clinical rating scales, which are discussed toward the end of the lecture to determine whether the patient has worsening or improvement in their symptoms. So usually these clinical trials define clinical response as at least a 50% reduction in the score on a depression rating scale, whereas they define clinical remission as a score within the normal range of that scale. So, what are our options for treatment of depression? For treatment recommendations, we'll briefly discuss some of the guidelines that have been published, such as the American Psychiatric Association, the CANMAT, which is the Canadian guidelines, and the NICE guidelines, which are the UK guidelines. And we'll review those in detail, but there are other guidelines included, such as the Institute for Clinical Systems Improvement, which came out in 2016 and also provides recommendations for treatment in that primary care setting. We do have the VA DoD guidelines, which is specific to the veteran population, but that did just come out this year with an update. We have the TMAP guidelines, which started in 1996 as a public and academic collaborative effort to develop medication guidelines for schizophrenia, MDD, and bipolar disorder. And then lastly, there are also NICE guidelines for children in treating MDD. And all of the links here take you to the guidelines. So we'll start by comparing APA to the NICE guidelines. APA was written in 2010, whereas the NICE guidelines have had continuous updates with the most recent update in 2022. So APA and NICE guidelines base their on initial recommendation on the severity of presentation. So with the APA guidelines, they make no recommendation for any specific antidepressant over another, except they do state that MAOIs should be used second line. They do state for most patients that SSRIs, SNRIs, mirtazapine, or bupropion are usually optimal, and that the use of MAOIs should be restricted to patients who do not respond to other treatments, just given the necessity for dietary restrictions and also drug-drug interactions. It does provide little guidance as to which combinations to use, when to use them, or whether to use combination treatment to enhance efficacy or to reduce side effects. ECT, or electroconvulsive therapy, is recommended for patients with treatment-resistant depression or those with significant functional impairment. It's also recommended for MDD with psychotic or catatonic features, or if they need an urgent response, such as the patient having suicidality or they're nutritionally compromised. Or you can just generally use it if the patient prefers ECT or they previously had a positive response. They do stress the importance of psychotherapy with antidepressants and other treatments. Now, looking at the NICE guidelines, they do have a couple of different recommendations. The major difference from APA is that for mild depression, they only recommend psychotherapy, and it's recommended based on the risk-benefit ratio kind of being poor. So they recommend to not routinely offer antidepressant medications as first line unless it's the person's preference. This psychotherapy can consist of many different types of therapy, including guided self-help, or group CBT, which is cognitive behavioral therapy, or individual CBT, and then there's many others. For moderate to severe, they can use an SSRI, SNRI, or other antidepressant if it's indicated, just based on their previous clinical and treatment history, but really SSRIs are generally well tolerated, and they have a good safety profile and should be considered as the first choice, according to the NICE guidelines. Drug treatment is recommended for patients with moderate to severe depression. The sub-threshold of depressive symptoms have to be present for a long period, so at least 2 years, or if they have sub-threshold of depressive symptoms or mild depression that persists after other interventions. So ECT, similar to APA, is recommended for severe life-threatening depression or treatment-resistant depression, or where they need a rapid response. It is not really recommended with moderate depression. The NICE guidelines also said to consider vortioxetine when there has been no or limited response to at least 2 previous antidepressants. Then looking at the Canadian guidelines, or the CANMAT guidelines, that were last updated in 2016, they recommend first line with SSRIs, SNRIs, or other newer agents just based on safety and tolerability over TCAs or MAOIs. Second line includes TCAs due to tolerability and safety issues. And then they also showed that quetiapine demonstrated efficacy in randomized controlled trials for unipolar non-psychiatric MDD, but relative lack of comparative data with SSRIs and newer agents. Sileligine is a selective MAO-B inhibitor with better tolerability than other MAOIs, but still is required drug and dietary restrictions. And then third line is MAOI due to tolerability, safety, and dietary and drug restrictions. Really, you can just see in general that there's no decisive algorithm and treatment plan, and that recommendations are based on, for initial pharmacotherapy, and considerations for augmentation or switching therapy. So it's more patient-based and their patient characteristics and what's preferred, and drug characteristics as well. Here is a further look in depth at the CANMAT recommendations for adjunct medication recommendations. They do recommend first-line adjunct with aripiprazole, quetiapine, or risperidone, and then after that, brexpiprazole, bupropion, lithium, mirtazapine, modafinil, olanzapine, and then T3 as well. And then third line is adding maybe other antidepressants or other stimulants, as well as TCAs or ziprasidone. And then when the CANMAT guidelines came out in 2016, ketamine was still experimental in MDD. So really overall, the approach would be for treatment to include pharmacotherapy alone or in combination with psychotherapy. ECT is really only warranted in severe cases. Psychotherapy is usually recommended in mild or moderate depression, with mild depression usually being monotherapy with psychotherapy. From the STAR*D trial, we did learn that effectively treating symptoms to remission early may have a decreased relapse rate, and that continued monitoring is necessary. So we want to continue treatment for patients with full response to medication after 4 weeks, but we want to continue to monitor at least at the 6, 8, and 12-week mark. If symptoms do persist at 4 weeks, we want to make sure to assess their adherence and optimize the dose as tolerated by the patient. Our current data continues to be unclear on whether it's better to increase the dose, augment with another medication, or just switch completely when there's been a partial response to therapy. But half of patients did see a response at 6 weeks with more intensive dosing initially, and there was really no difference between switching or augmenting even with patient preference. So combination psychotherapy and pharmacotherapy in adults has not really demonstrated an improved response rate, but is still recommended in mild depression. So essentially, we want to use an individualized treatment plan that's more important based on patient characteristics and drug characteristics as well, as stressed before. And based on medications that we talked about before, some of the medications can help with other comorbidities as well. So as you can see here for sleep, trazodone, mirtazapine, and paroxetine, based on their adverse effects of somnolence, can help with insomnia. For concentration, bupropion can help, as well as duloxetine and fluoxetine. For anxiety, we see sertraline, fluvoxamine, paroxetine, and SNRIs as beneficial. And then for pain, as discussed before, the SNRIs can be helpful with musculoskeletal and neuropathy. So given the guidelines and what we discussed, pharmacotherapy should really be based on the following: past response, or even if a family member responded, that medication could be helpful for you as well, or the patient as well. Other psychiatric comorbidities, whether they're going to have potential drug interactions, the safety of the medication, patient preference is always important as well, and then the cost. It's really essential so that we can enhance adherence and then prevent side effects of medications too. So while some meta-analyses have shown improvement over others, in general, usually all antidepressants are considered equal. So we just want to continue monitoring with rating scales. So let's return to MB. Based on her diagnosis, what would you recommend for treatment? And this may be different from what I would recommend because, again, it's patient preference. It's what you think as a clinician as well. So I would recommend psychotherapy, discussing with the patient what she would prefer, CBT, groups. And then I would recommend either an SSRI, so fluoxetine, escitalopram, sertraline, or another SSRI, or an SNRI, such as duloxetine. I would more so go on the lines of doing duloxetine because she has that chronic pain, past medical history as well, but I would discuss with the patient as well what she would prefer. As we discussed before, there are rating scales, and that's how we clinically monitor response to medications. I won't go into detail all of the scales because they can be looked up and you can refer to them there. But majority of the time we do use the PHQ-9, which is the Patient Health Questionnaire. It's routine screening and a monitoring tool. One of the scales, the Hamilton Rating Scale for Depression, or HAM-D, is usually used in clinical trials as well. And then there's these other scales that you can look into. So with MB, prior to treatment, her PHQ-9 was given to her, and she scored an 18, which indicates moderately severe depression. She's been taking her duloxetine and participating in CBT for the past 6 weeks. So she comes into clinic and you repeat her PHQ-9, and now she scores, after 6 weeks of therapy, a 7. So how would you classify this? Would it be a clinical response, clinical remission, or neither? So I would classify her as having a clinical response because her score did decrease by 50%, and she's not in remission yet because her score still indicates mild depression. She's not in that no depression score range yet. So when we're educating patients, we want to make sure when we're counseling that we counsel them on when the medication is going to start working, so that it may take 4 to 6 weeks to even see an effect, what to expect when taking the medication, so the side effects we discussed, and then also the discontinuation syndrome. So counsel them on not abruptly discontinuing their medication, and to discuss with a provider if they're having any issues that would prompt them to stop their medication. We do want to let them know for duration of therapy. If this is their first episode, they may be taking the medication for at least 6 months. If it's their second episode, they could be taking it for at least a year. And then if they're on their third episode or more, likely they'll be on an antidepressant for lifetime. Finally, we're going to wrap up to talk about some newer medications for MDD. First, we're going to start with esketamine, or brand name Spravato. It was approved in March of 2019. And its indication is as an adjunct to oral antidepressants for the treatment of treatment-resistant depression in adults. It works by being an NMDA antagonist, where it facilitates release of glutamate, which leads to AMPA receptor activation. It does have some black box warnings, including a risk for sedation and dissociation after administration, so we want to monitor the patients for at least 2 hours after their administration. There is also potential for abuse and misuse, so we want to monitor for signs and symptoms of that. There's also increased risk of suicidal thoughts and behaviors in the pediatric and young adult patients taking antidepressants. So we closely monitor all antidepressant treated patients for clinical worsening and emergence of suicidal thoughts and behaviors. It's actually not approved for use in pediatric patients. Spravato is part of a REMS program, so these healthcare settings that are certified in the program have to ensure that it's only dispensed in the healthcare setting and administered to patients who are enrolled in the program. It is administered by the patients under the direct observation of a healthcare provider, so the patients do spray it up their nose, and the healthcare provider watches them to make sure they get the full dose. And then these healthcare providers monitor them for at least 2 hours after giving them the medication. And the pharmacies dispensing the medications have to be certified in REMS as well. And as you can see the price here, it is pretty pricey, but just from patient interviews that have taken the Spravato, they have said that Spravato has been very helpful in their treatment-resistant depression. Some side effects that occur with Spravato, kind of similar to regular ketamine, include dizziness, GI, such as nausea, vomiting, and dry mouth, sedation, which is transient, so it happens when they first take the dose and then wears off. And then dissociation is a common one, up to 75%. So this usually occurs shortly after the dose is given, and then will alleviate about an hour and a half after their dose. So this could include derealization, depersonalization, and just distortion of time and space. And then it can also increase their blood pressure, so we monitor their blood pressure before they take the dose and then throughout the 2 hours that they're observed. The last new medication we'll review is brexanolone, and it was approved in March 2019. It's a GABA A positive modulator, or allopregnanolone. Its indication is for postpartum depression in adult women. It's administered by an infusion over 60 hours at a healthcare facility. We do usually see clinical improvement within 24 to 60 hours after starting the infusion, and the effect has been demonstrated to last up to 30 days after the infusion. Does come with some black box warnings, such as excessive sedation and sudden loss of consciousness. Other side effects include dizziness, infusion site reactions, and flushing. Similar to Spravato, it does have a REMS program, so it can only be administered by a healthcare provider in a certified healthcare facility. We want to monitor for that excessive sedation and loss of consciousness, and then these patients have to be accompanied during interactions with their children. And again, it comes with a high price as well, but it is indicated for postpartum depression. Here are my references. Please feel free to reach out to me or Dr. Reinstatler with any questions. Thank you.